Good evening, everyone, and welcome to our EEL webinar. Today, we will have Professor Paolo Vercellini, who will be talking about endometriosis and ovarian cancer. And we're going to have Dr. Marina Kvaskoff as moderator. Before we start, I'd like to inform you that this conference will be recorded. And if you don't want to be involved, then you have to click no. Dr. Marina Kvaskoff, welcome again. It's a great pleasure to have you here. She has done her public health degree in Bordeaux, France. At the moment, she's living in Paris. And she did her PhD on public health and epidemiology in France and Australia. And she has accreditation to supervise research. She is a group leader and tumor sciences at INSERM, and she has done postdoctoral fellowships in different countries over the years. Also, at the moment, she is the principal investigator of the Compare Endometriosis cohort, and she is the scientific committee chair of French Foundation for Research on Endometriosis. Dr. Marina, it's a great pleasure to have you here today again. And I'd like to hand it off to you so you can also start moderating. Thank you.
Thank you very much for the invitation to moderate this webinar. It is really a very big pleasure and honor to introduce our speaker this evening, Professor Vercellini. Professor Vercellini is Professor of Obstetrics and Gynecology at the University of Milan in Italy and Director of the Gynecology Unit at the Luigi Mangiagalli Institute in Milan. He initiated the activity of the Mangiagalli Endometriosis Center, which is now a national referral service for women with severe disease. He has extensive experience in the management of endometriosis and adenomyosis, and his research interests include the investigation of some pathogenic aspects of the diseases and the assessment of the medical and surgical treatments. He's extremely recognized internationally in the field and has published over 400 scientific articles. He's a past member of the executive committee of the ESHRE and also a World Endometriosis Society ambassador and past president. I'm very much looking forward to his presentation on endometriosis and cancer. Thank you, Professor Vercellini.
Thank you very much. Good evening to everybody. Sorry.
Professor, before we go ahead and start, can I kindly ask for a minute of your time so we can show the video from our sponsor, Gideon Richter?
Oh, of course, of course.
Alan?
What does it take to make a medicine? You need to shift your perspective to see success comes from a series of innovations. Without the dedicated work of our highly trained researchers, no such progress would be possible. It is today that experts need to think about the diseases of tomorrow, and premium quality requires the latest technology. All these aspects come together to create new treatments that will improve the health of millions. This is what we work for every day. Gideon Richter, health is our mission.
Thank you very much, Professor. Can you please share your screen?
Okay.
Perfect.
And thanks to the European Endometriosis League, to Professor Oral, and to Dr. Kvaskoff for the invitation, the moderation. Indeed, I don't feel very comfortable giving this presentation with Dr. Kvaskoff as my moderator, because probably she should have presented this topic and I should have moderated her. These are... Oh, okay. These are my financial competing interests in the past 5 years. So I received compensation from UpToDate for writing and revising 3 chapters on endometriosis, and I undertake both public and private gynecological practice. A vast amount of data in the past year strongly suggest that the so-called endometriosis-associated ovarian cancers arise from endometriosis. Indeed, many authoritative pathologists believe that some specific histotype of epithelial ovarian cancer derives from endometriosis. To verify whether there is an association between endometriosis and epithelial ovarian cancers, several systematic reviews and meta-analyses have been performed in the past decade. However, in my opinion, the best written, the most analytical one is the one recently published by Marina Kvaskoff and co-workers just a few months ago. And the authors have collected data from 24 studies published in the last 20 years. And as you can see, the pooled estimate of the risk of ovarian cancer in women with endometriosis is almost double, is 1.9. The confidence interval is very narrow because it goes from 1.7 to 2. There is some heterogeneity, but the largest studies are fairly consistent, and they indicate a relative risk ranging from 1.4 to 1.7 and 1.9. This is the association with all epithelial ovarian cancers in general. However, there are some more robust association because the two histotypes that are specifically associated with endometriosis are the clear cell histotype. I don't understand why. The clear cell histotype with a relative risk of over 3, we suggest a causative association, a relationship, and the endometrioid histotype. Also, there is a statistically significant association also with the serous histotype, but then in this case only with the low-grade serous. So overall, an association with the so-called type 1 epithelial endometrial cancers. Interestingly, the association is more robust in cohort studies and less so in case control studies. And among the cohort studies is stronger when the design was prospective compared with retrospective. So the better the study design, the stronger the association. And these suggest the validity of the general concept of an association between endometriosis and ovarian cancer. And the authors focus the attention also on two opposite factors that may have an impact on the risk on the estimate of the risk. On one side, the authors observed a possible publication bias, which means that the 1.9 estimate might be excessive. But on the other side, in the so-called unexposed group, in both case control and cohort studies, most probably there will be cases of unrecognized endometriosis, which as consequence would attenuate the quantified association. So it's fairly difficult to understand which of the two factors has a larger effect on the estimate. But the results were fairly consistent in the largest studies, at least. And Another point is, are all the endometriotic lesions at the same risk of neoplastic derailments, or is there a difference between various types of lesions, and specifically peritoneal, superficial peritoneal lesion, ovarian lesion, and deep lesion? And many authors suggest that the ovary is the main site of neoplastic transformation, although Marina Kvaskoff and co-workers underline the fact that it's not easy to exclude that, based on the available data, to exclude that peritoneal endometriosis does not undergo a neoplastic change, or deep endometriotic lesions, also because in most cases, there is a mixture of lesions, so it's not very easy to specifically define the risk of the various histotypes, because in most cases, they are all mixed together. However, it has been suggested that when an endometriotic cyst is present, the risk of the long-term risk of malignant transformation is between 0.5 and 1%. And taking into consideration that the overall lifetime risk of ovarian cancers in the let's say average risk general population is slightly over 1%, adding this risk in women with ovarian cyst, we may calculate an overall risk between 1.5 and 2%, which is the risk that has been observed in most, in the largest epidemiological studies. And specifically, these authors from Finland studied the risk of endometriosis when the lesions were categorized among ovarian, peritoneal, and deep infiltrating. They retrieved data for almost 15,000 women with a surgical diagnosis of endometriosis, and they crossed the data with the Finnish Cancer Registry, considering as the reference the Finnish female population. And whereas overall, the overall risk is almost 1.8, which is in line with the previous data that I've shown. Again, the most robust association is with a clear cell histotype over 5 is the standardized incidence ratio, and over 3 for the endometrioid histotype. But when we come to the specific lesion types, we see that whereas the ovarian lesions are associated with ovarian cancers with a standardized incidence ratio of 2.56, and the association is obviously much more robust with the endometrioid and the clear cell histotypes. The association is not, there is no statistical association when considering the peritoneal lesions, only a very significant association only with the endometrioid histotype, whereas deep lesions do not seem to be at risk of cancerization. However, even if some relative risk may be impressive, a relative risk of 5 is really impressive. Indeed, at the end, the absolute sex risk is small. And to give an absolute estimate, it means that only 2 excess cases among 1,000 patients will develop ovarian cancer, and during 10 years of follow-up. So overall, the impact on the women with endometriosis in terms of risk of developing cancer is not so large as the relative risk might suggest at first sight. And we will see why. Another point to be addressed is endometriosis to be considered a precursor lesion? Because if this is so, this would imply a much more aggressive management of endometriosis. But considering endometriosis tout court as a precursor lesion would mean as considering the eutiopic endometrium as the precursor lesion of endometrioid adenocarcinomas, which is obviously not true. So the precursor lesion of the endometrioid adenocarcinomas that develop inside the uterine cavity is atypical hyperplasia. And the same pattern has been observed also in endometriosis, although the data are scanty, unfortunately. But probably, according to several authors, not endometriosis in general, but atypical endometriosis should be considered the precursor lesion. And endometriosis has been categorized as low or high risk. Low risk when no atypia is observed on excised lesion, and high risk when atypia is observed. Even within the chapter of atypical endometriosis, there are differences, because in the vast majority of cases, only mild or moderate cytologic atypia is observed. And in most instances, this is the result of the inflammatory environment within an endometriotic cyst, or sometimes even as a result of the progestin therapy that has been used just before the surgical procedure. Whereas if there is architectural atypia, which means hyperplasia, associated with severe cytological atypia, this cannot be considered a response to inflammation, and this finding is strongly associated with ovarian cancer. So if architectural atypia with severe cytological atypia is observed, further surgical procedures should be undertaken, whereas if only mild to moderate cytologic atypia is observed in endometriotic cyst, these women can be followed up without further immediate surgical procedures. The problem is that nobody knows how these women with mild to moderate cytological atypia should be followed up during the years, because most of these women seek pregnancy or will seek pregnancy in the future. So it's not feasible to consider even a unilateral salpingo-oophorectomy. But no guidelines tell us how to behave in these cases, how frequently to perform ultrasound scans, how frequently to perform CA-125 monitoring, and which cutoff should we consider sufficiently high to undergo another surgical procedure. So unfortunately, this is a topic that should be developed more in detail in the future, also because in our center, but I know also in several other referral centers, the histologic diagnosis of atypical endometriosis is growing in frequency. So this is a problem that we should address in the near future. If this is so, if endometriosis is associated with an with ovarian cancer. And so the first answer is yes, endometriosis is associated with ovarian cancer and with specific histotypes. But the other answer is there a difference in the risk if these women undergo surgery or not? So if lesions are excised or not? There are very few data. And as an example, this is one study published in 2008 and based on few cases, on less than 100 cases. But it seems that, it seems that women who did not undergo surgery develop are at higher risk, especially for clear cell and endometrioid ovarian cancer, with respect to those women, admittedly very few, who underwent surgery before the diagnosis of ovarian cancer. So it seems that surgery is protective toward the risk of developing ovarian cancer. In particular, but this is of course, in particular, unilateral salpingo-oophorectomy. But of course, unilateral salpingo-oophorectomy is protective because by definition, it reduces the risk by 50%. And also this study published in 2013 and based on a total of 220 women diagnosed with epithelial ovarian cancer at least 1 year after the endometriosis diagnosis. This is another point that has been underlined correctly by Marina, Kvaskoff, and co-workers. So there should be a time gap between the diagnosis of endometriosis, a reasonable time gap between the diagnosis of endometriosis and the diagnosis of ovarian cancers. Otherwise, the suspect is that that lesion probably harbored neoplastic foci even in the beginning. So it was already a cancer. So not only endometriosis. However, in this study, radical excision of endometriosis seems to be very protective towards the risk of ovarian cancer, and again, particularly unilateral salpingo-oophorectomy. So, if surgery, endometriosis surgery, is protective, what should we do? Should we screen the entire general population? And should we screen to try to identify what? Early stage ovarian cancer or endometriosis in general? With regard to the issue of screening for ovarian cancer, I would like to draw your attention on the fact these data have been published very recently in Lancet and are the long-term results, the 16-year follow-up results after randomization to 3 different groups. In the UK, 50,000 women have been randomized to a so-called multimodal follow-up and screening, a combination of CA-125 and ultrasound scan. 50,000 women have been randomized to only ultrasound scan, and 100,000 women did not undergo screening for ovarian cancer. After 16 years, the incidence of invasive epithelial and tubal cancers is identical. And the cumulative mortality for ovarian and tubal cancer is identical in the 3 groups. So this is to underscore that screening is not synonymous with increased in reduced mortality, disease-specific mortality from that cancer. And indeed, the authors wrote that before general population screening is introduced, and this is in general, not only for ovarian cancer, because only a few disorders benefit from screening to reduce disease-specific mortality. But before screening, population screening is introduced, any new test is shown to should be shown to reduce deaths in a future randomized controlled trial. Also because this type of screening consume a huge amount of resources. So just try to imagine how much healthcare resources should be are needed to screen the general population to identify endometriotic lesions. So at the moment, as it has been suggested also by the group of Marina Kvaskoff, there is no rationale to think about screening the general population. Moreover, we should consider that endometriosis is strongly associated with two histotypes that are not very frequent, because by far the most frequent histotype is the so-called high-grade serous tumor that is present in about 65-70% of a series of epithelial of ovarian cancer, whereas, as we will see, clear cells ovarian cancers plus endometrioid ovarian cancers are no more than 15 to 20% of the largest series available in the literature. So there is a strong association with the two histotypes that are not very frequent. So at the end, even if women with endometriosis are at 4- or 5-fold higher risk of these specific histotypes, the number of cases will still be too small to justify a population-based screenings. And the same concept has been expressed by Marina, who wrote that currently no resource utilizing cancer screening guidelines should be made due to the presence of endometriosis alone. But she focused on the fact that heightened screening only could be considered for those with known non-endometriosis specific risk factors. So endometriosis plus other independent risk factors, and we will talk a little bit more on this aspect. In a mathematical model, it has been calculated that So what can we do if screening is not a good idea? Could we think about performing risk-reducing surgery in women with endometriosis? Again, risk-reducing surgery, which has been suggested in the past years by several authoritative investigators in endometriosis, should be really balanced against not only costs, but also against the risk of performing a bilateral salpingo-oophorectomy in women with endometriosis, because the procedure is not as easy as in women without endometriosis or in women who did not undergo previous surgical procedures. Women with endometriosis very often underwent several surgical procedures before eventually undergoing a bilateral salpingo-oophorectomy. And this type of procedures may not be as straightforward as in women who undergo risk-reducing salpingo-oophorectomy, for instance, for BRCA1 or 2, BRCA1 or 2 mutations. And it has been estimated that in these cases, the relative risk should be greater than 4% in premenopausal women and greater than 5% in premenopausal women to justify risk-reducing salpingo-oophorectomy. But even when considering risk-reducing salpingo-oophorectomy, in another two issues should be considered. If the woman is premenopausal, the issue is, will this woman take HRT, and will she adhere to this therapy until the age of 50 years? Because if premenopausal women cannot take or will not take, are unwilling to take hormonal replacement therapy, the lifetime ovarian cancer risk threshold is higher than 4 or 5, but should be higher than 8, because a premature menopause increases the risk of several other adverse events, including cardiovascular events, so that you may not die by ovarian cancer, but you may die from cardiovascular events such as stroke or myocardial infections. And this is an impressive sentence, because Mullen and co-workers wrote that in an hypothetical cohort of 10,000 average risk women undergoing oophorectomy at, let's say, 50 years of age, by the time the cohort reaches 80 years, only 47 fewer women would die from ovarian cancer, but more than 800 would die for cardiovascular heart disease, and about 150 from hip fracture. When considering all endometriosis patients, risk-reducing surgery would not be cost-effective, or probably would not be effective at all. However, if we adopt inadequate risk modeling in endometriosis patients, probably we could focus some preventive strategies in a limited number of patients. And in this group, in this subgroup, limited subgroup, risk-reducing surgery could be feasible and cost-effective. And Pierce has calculated this in this modeling, the lifetime risk of developing ovarian cancer in specific subgroups of women when combined risk factor in addition to endometriosis. So oral contraceptive, lifetime oral, the duration of oral contraceptive use during reproductive life, parity, we know very well that parity is protective, oral contraceptive use is protective, family history is strongly is a strong risk factor for ovarian cancer, and of course, genetic predisposition such obviously would increase greatly the risk of ovarian cancer. So in some subgroups, the combination, in some subgroups of women with endometriosis, the combination of these factors, so if a woman not only has endometriosis, but is also nulliparous, has never used oral contraceptive, has a family history of ovarian cancer, it might be worthwhile to consider risk-reducing salpingo-oophorectomy. This is in women without endometriomas. So in all women, with endometriosis, independently of the presence of endometriomas. However, the same authors, so Pierce and co-workers, consider that risk-reducing salpingo-oophorectomy is not the only alternative, because I am impressed by how little we talk about the alternative modality to reduce the risk of developing ovarian cancer in general in women in reproductive years, but specifically in women with endometriosis, which is the extended use of oral contraceptives. And in this regard, I would like to draw your attention on the recently published...
We agree in the lifetime number of ovulatory cycles.
Excuse me, I did not understand. Hello?
I think you can go on.
Oh, because it's too late.
No, that was an error. That was a mistake, I think.
Oh, okay. So, I would like to draw your attention on the effect of oral contraceptives on the risk of ovarian cancer. These are the data published recently in Cancer Research, deriving from 20 prospective studies from all over the world. And more than 500,000 naturally menopausal women across 20 prospective cohort studies, including more than 2,000 grade serous cancer, more than 300 endometrioid, and 121 killer cells cancers. And let's take a look on the effect of the number of ovulations, lifetime ovulation, on the risk of ovarian cancer. So, women who, for several reasons, pregnancies or the long-term use of oral contraceptives, have few ovulatory cycles in the lower quartile or in the lower 10th percentile, have a reduced risk of ovarian cancers, whereas the higher the number of ovulatory cycles, the higher the risk of developing ovarian cancers. So there is a doubling in the risk comparing those women with the lowest number of ovulatory cycles with the group in the highest in the highest group with more than 500 ovulatory cycles in their reproductive years. So ovulation is a very strong risk factor, and in particular, any 5-year period of uninterrupted ovulation, there is a 40% increase in the risk of ovarian cancer. The opposite is true. If we inhibit ovulation with oral contraceptives, we see a strong protective effect And indeed, 10 years of use of oral contraception means a reduction in risk of about 40%. Of course, once contraception is withdrawn, the risk tends to reduce over the years, but still you can see a strong reduction in the risk even 30 years after discontinuation of oral contraception. So my question, of course, the reduction is not specifically in endometriosis-associated cancers, so clear cells and endometrioid cancer. But obviously, the effect of oral contraception is mostly on the high-grade serous tumors. But do women with endometriosis care about the histotype of ovarian cancer that is causing their death? No, they don't, I believe. They don't want to die from ovarian cancer, independently of the histotype. So my consideration is, if a population of women with endometriosis should be considered at higher risk of ovarian cancer with a doubling of risk, why not using, instead of thinking about screening, about risk-reducing surgery, why do not we think about using extensively and for a long period of times oral contraceptives or progestins which inhibit ovulation? And so we reduce the risk of ovarian cancer much more than thinking about screening even in a specific group of women. And indeed, Modugno has published the pooled data from 4 population-based studies in 2004, and they observed that in women with endometriosis, if they have used oral contraceptives for 10 or more years, the risk of ovarian tremendously reduced compared with the general population. But the usual criticism to this potential strategy to reduce ovarian cancer is oral contraceptives are associated with venous thromboembolism. So we increase the risk of death simply by giving oral contraceptive. Well, okay, let's take a look at the facts. So the risk of venous thromboembolism is about 3-fold in women using oral contraceptives compared with the general population. So this means that with second, third generation oral contraceptives, we should treat 1,000 women for 1 year to cause an additional event of thromboembolism. But given that death occurs in about 1% of all cases of venous thromboembolism, this means that in women in reproductive years, oral contraceptives cause approximately 1 additional death per 100,000 women each year of use. So if we use oral contraceptive for a period of 10 years, this will cause 1 death every 10,000 women, which is much, much less than the additional risk of dying from ovarian cancer when not using oral contraceptives in women with endometriosis. And let's go to the last point of my presentation. What should be told to our women? Our women should receive absolute estimates, not relative risk. They do not care about relative risk and probably do not understand what does it mean, a relative risk. If we say to our women, you have a 90% increase in the risk of ovarian cancer, they would ask for risk-reducing surgery next day, of course. So we should offer them, we should provide very simple estimates that they can easily understand to take their decision, because each woman is different. So there is no general rule for all women, because women tend to accept different risk. There is some women that a priority for some women is not to go to the operating room to avoid the risk of surgery. For someone else is not taking oral contraceptives, so there are several attitudes in women with endometriosis. And again, Dr. Kvaskoff and co-workers indicated some very useful information to provide to women with endometriosis. So that the lifetime ovarian cancer risk is increased from about 1 in 67 women to 1 in 55 women. Then screening is inopportune, and that can lead to overtreatment, so useless surgery. And that risk-reducing surgery is associated with potential surgical and non-surgical harm. And they have also underscored that they focus the attention on the fact that there is no reason to consider at the moment screening, and that clinicians should reassure women with endometriosis, and that bilateral salpingo-oophorectomy in women without endometriomas solely to prevent ovarian cancer is not justified. So, in conclusion, what should we do in women with a history of endometriosis but without endometriotic cyst? Because this is, in everyday practice, this is the real problem. What should we do in women with not only with a history of endometriosis, with histologic diagnosis, but with a current endometrioma? So women who does not want pregnancies any longer, but has 3 to 4 centimeter endometriomas. What should we do? Because of course, women with large endometriomas should be operated, but what should we do in women with small endometriomas? So in conclusion, this is what we should face in everyday practice. So women with a history of endometriomas but without endometriomas can undergo surveillance, so not screening, surveillance, and not risk-reducing surgery, unless they are at substantially increased risk, so with a positive family history of ovarian cancer, infertility, and so on, as the risk factors that we considered before, or if in the past there was an histologic diagnosis of moderate cytological or structural atypia in a previously excised endometrioma. So in this limited subgroup of women, even without endometriomas present, risk-reducing surgery might be considered. When during surveillance, all women who develop an endometriomas after the age of 45 years should undergo removal of the affected ovary, because in this case, the risk of neoplastic lesions inside the cyst is much higher than in other conditions. What to do in women with small endometriomas? Surgery is mandatory in case there are modifications in size of US or ultrasonographic characteristics in post-menopause or in pre-menopause during hormonal therapy. If an endometrioma increases in size or modifies its ultrasonographic characteristics during oral contraceptives or during progestin treatment, this woman should undergo immediate surgery. Or if there are relapsing or worsening pelvic pain symptoms in post-menopause. And finally, the decision between the alternatives should be individualized. So a sort of personalized medicine in these circumstances, because the therapeutic balance varies among strata of age and different clinical conditions, but the overall goal should be providing quantitative and simple information to women to allow them to take their decision together with us and to provide high-value care whilst avoiding medical overuse. Thank you very much for your attention.
Thank you very much, Professor Vercellini, for this very nice overview and update on the topic. It was a very nice presentation of the critical issues of monitoring and radical surgery on this very situation. And it was quite a challenge to present all this, so well done on this. I was particularly interested in your proposition to use oral contraceptives for the prevention of ovarian cancer. Would you recommend using this regardless of menopausal status, or would it be only in premenopausal women?
No, obviously in premenopause, certainly in premenopause.
Right. Okay.
Because the objective is to inhibit ovulation. And I showed this data. I've shown this data because I don't know you, but I'm impressed by the fact that almost nobody speaks about this beneficial effect of oral contraceptives and progestins. There are limited data. The rationale is the same. So inhibition of ovulation. There is another voice. Can you hear me?
Yes, I can hear you.
Okay. Everybody talks about screening, about risk-reducing surgery, which type of surveillance we should propose. But very few people talk about this additional benefit of a standard therapy for medical therapy for women with endometriosis, which is reduction of the ovarian cancer risk.
Mm-hmm. Well, that was a very nice demonstration of the balance between the benefits and risks. An additional issue is what to do in postmenopausal women. And so could you summarize your recommendation for postmenopausal women? Do you have one particular recommendation, or do you recommend a case-by-case basis?
Postmenopausal women with a history of endometriosis, without endometriomas, so without endometriotic cysts, and who are asymptomatic and do not have additional risk factors for ovarian cancer, might undergo simple surveillance, nothing more. Whereas if there are additional several risk factors, probably risk-reducing surgery might be discussed, not undertaken, but discussed. And obviously, the discussions should take into adequate account also additional surgical risk factor, such as previous difficult surgical procedures or concomitant morbidity, morbid obesity, so that the surgical procedure could be at higher risk with respect to, let's say, average risk women, average surgical risk women, because women are not all the same in terms of even of surgical risk. And there is one event that should be avoided, absolutely avoided, in premenopausal women. But I would take the occasion to talk about also the so-called residual ovary syndrome. So if in premenopausal women you try to perform a bilateral salpingo-oophorectomy, but you leave a small amount of ovarian cortex, even of a small amount, this is a very potentially dangerous situation for this condition called the residual ovary syndrome, which may even lead to, because of formation of several ovarian cysts, even can lead to ureteral damage. We have seen several cases of this situation. So, taking out the ovaries in women with endometriosis is not the same as risk-reducing surgery for women with BRCA1 and 2 mutations. So it's not the same. In postmenopausal women with small endometriomas, much care should be taken to follow these women, and in my opinion, and the opinion in several other authors, clinicians, surgery should be undertaken whenever there is an increase in not only in the dimension, but also in the ultrasonographic characteristics of these small endometriomas. Because, sometimes you don't know what to do. This woman has 50 years and 2 centimeter endometrioma. So after you have treated these women for years and years without operating her, and what to do now because the cyst remains. So you have not suggested or not proposed salpingo-oophorectomy during all the past years, and now that she reached the menopause, at this moment you suggest undergoing surgery. So it's difficult sometimes, but at least they should be followed very strictly, and surgery should be undertaken whenever the cyst increases in diameter, or a modification in ultrasonographic characteristics is observed, or if the women in postmenopause refer for pelvic pain, which was not present before.
Right. Thank you very much. That's very clear. We've got a few questions that came in through the chat. So a series of questions on atypical endometriosis from Taina Usta. So I'm going to read the questions. You mentioned about atypical endometriosis. So in our clinical practice, we cannot see that definition by the histopathologist. So there are 3 questions. First, how can you explain the situation? Second, is there any number about prevalence of atypical endometriosis? And third, in terms of cancer risk, is there any difference between ovarian endometrioma and deep endometriosis of bowels? Thank you so much for your presentation.
Thank you for the very interesting questions. So I don't know why, I mean, there is probably a difference between centers, between hospitals, also in the awareness of pathologists towards atypical endometriosis. I noticed in my hospitals an increasing awareness through the years. So probably atypical endometriosis was not a frequent finding 20, 30 years ago, whereas nowadays it's fairly frequent finding. But there are atypical endometriosis is described in publications and in famous pathology textbooks. So there is cytologic atypia and architectural atypia, mild, moderate, and severe degrees. So I believe that pathologists in large hospitals should be very aware about this. The prevalence of atypical endometriosis has been observed in about between 1 and 3% of all excised endometriomas. But, saying atypical endometriosis means little if you do not specify if it is mild or moderate cytological atypia, which can be followed without further measures, because there is also the hypothesis that when you excise an endometriotic cyst, you observe an atypical lesions, but probably the atypical lesions has been removed. So the ovaries has been cured. To give you an example, where you perform an excision of a dysplastic lesion on the cervix. When you excise the entire lesion, usually the follow-up is straightforward without further recurrences, usually. If there was a moderate cytological atypia with some hyperplastic aspect, of course, this lesion is at increased risk of ovarian cancer. And some pathologists believe that this is the real precursor lesion, not endometriosis per se. Deep endometriosis, I know, Marina, that you do not agree very much on this point. I mean, reading your excellent systematic review published on Human Reproduction Update. But based on the available data, it does not seem that deep endometriotic lesions are at high risk of neoplastic derailments. Indeed, the cases of cancer found in rectovaginal lesions, in deep endometriotic lesions, is, there are, I believe, something like between 30 to 40 published cases in the entire scientific literature. So at the moment, most investigators believe that deep lesions, where both in the bowel and in the rectum and the vagina, are at limited risk of cancerization.
Yes, well, we actually agree on this point.
Oh yes, but if I understood well, you maintain that because the different lesions are very frequently mixed, it's difficult to say from which specific lesion the cancer developed.
Yes. Yes, in truth, we need more data that looks at and specifies all the different types of endometriosis present and in which types the cancer arises. So that's the limitation of the literature. There's a couple more questions. So a question from Tena Usta, again, when you face a woman over 45 years old and diagnose endometriosis, what would you recommend to her? First choice would be surgery is harmful, or second, mention about risks of OC and recommend surgery?
Without endometriomas present.
Doesn't say, but I guess.
So without endometriomas present, I would inform in detail, in simple terms, about the situation, and I would discuss with the woman. But in the absence of additional risk factors, And without endometriomas, I would not suggest risk-reducing surgery, which means bilateral salpingo-forectomy, because over 45 years, what does it mean? What does it mean? 46 or does it mean 51? I mean, there is a number of years in between, and the potential harms deriving from risk-reducing surgery, in case this woman would not adhere, would not use hormonal replacement therapy for at least 4 or 5 years, the consequences, so the harms, would be worse than the risk, the increased risk in ovarian cancer.
Right. So another question from Katerina Exakustos. Paolo, thank you for this interesting lecture. My concerns on prolonged ovarian cancer on risk on breast cancer or other cancer. Do you have some data on it?
Hi, Katerina. The use, if I understood well, the effect of oral contraceptives on breast cancer. Is it correct?
Yes, I think so. I think OCs for oral contraceptive, prolonged oral contraceptive use on the risk of breast or other cancer.
Yes, we all know that there is a slight increase in risk in breast cancer in oral contraceptive users. The risk could be estimated in about 1.2, 1.3. However, we also now know the very long-term follow-up data of the cohort studies undertaken in the UK regarding the use of oral contraceptions, and we know that there is now no single cause of death, including breast cancer, which is more frequent in past oral contraceptive users compared with non-users. Also because the use of oral contraceptives is generally in the 30s or 40s, when the peak in breast cancer incidence has not yet been reached. And we know that after oral contraception discontinuation, the risk during the years is reduced. So I do not believe that the number of deaths we prevent, the number of deaths from ovarian cancer we prevent is counterbalanced by an increase in the number of deaths we cause because of oral contraceptive use. But here I believe that you, Marina, you may say much more reliable facts, consideration that I can do. What do you think?
Well, yes, as you say, there is an increased risk in breast cancer that is well known, but it's modest. Does it counterbalance the risk of ovarian cancer? That's a good question. We need to look at numbers more closely. But as you say, I don't believe it results in many breast cancer deaths, and that, you know, prevention of ovarian cancer is definitely done with OCU. So yeah, well, we need to look at numbers more closely.
Because one point is the increasing risk in breast cancers. Another point is an increasing risk of death from breast cancer, because most women with the diagnosis of ovarian cancer do not die because of their breast cancer, do not die because of their breast cancer, where unfortunately most women with the diagnosis of epithelial ovarian cancer do die because of their
Paolo, Caterina, I stop you because I know that there is a higher risk of breast cancer as thyroid cancer in endometriotic patients. So that means you have to add also the risk in particularly in the endometriotic patients, which are a little bit more at risk for breast cancer and other comorbidities like thyroid and so on. So the balance to make so much hormonal therapy, I don't know if the data can give us some news about this, but the fear of the woman is this, to make a lot of therapy and to have fear of breast cancer and other cancers.
Yes, but Marina, would you add a comment on the association between endometriosis and breast and thyroid cancer?
Yes, so in the meta-analysis, we found a 4% increase in the risk of breast cancer associated with endometriosis, compared to, this risk was 93% with ovarian cancer, and it was 39% higher risk for thyroid cancer. But so for the ASHRAE guideline for endometriosis, the update that we just drafted, we looked at this very question because that's indeed a concern for patients who use OCs on long term. And what we say is that there is robust evidence from studies in the general population on the high risk of ovarian, endometrial, and colorectal cancers. The decreased risk of ovarian, endometrial, and colorectal cancer in women who use OCs. And there is a slightly higher risk of breast and cervical cancers. But when you look at the big picture, basically the higher risk, those risks are counterbalanced because the risk reduction that is offered for ovarian, endometrial, and colorectal cancers actually probably outweigh the increased risk for breast cancer. So it's exactly what you were just discussing, and looking at the numbers, that's the work that we did, and that's what we think happens. So there's another question from Engen Oral. If you have a case of a 46-year-old woman who has a 6-centimeter endometrioma from the last 5 years, or who has a newly diagnosed 6-centimeter endometrioma, which one is more at risk for endometriosis-associated ovarian cancer? So 6-centimeter endometrioma that's been there for the past 5 years, or a newly diagnosed 6-centimeter endometrioma, which one is more at risk?
The newly diagnosed endometrioma is at a much higher risk and should undergo surgery without doubt, in my opinion. A newly diagnosed endometriotic cyst after the age of 45 should undergo surgery. I understand the issue of endometrioma persisting through the years, which you have observed and managed in the previous years. What to do when the age increases, and well, 6 centimeter is a fairly large cyst. And I think that even if this cyst has been present for many, many years, at the end, we should also balance the weight of the type of surveillance we should be strict in this case for years and years to come, and also potential anxiety for the patient. At the end, I would suggest, at least based on my experience, not based on data, also because whenever you indicate a cutoff 5 centimeters or 3 centimeters, it's based on very limited data. But I think that unless this woman is at a highly increased surgical risk, I would suggest to remove the ovary. And at the same time, I believe that at 46 years, there is no further desire for pregnancy. At the same time, remove the tubes, because in this way, we not only reduce the risk of endometriosis associated ovarian cancers, so endometrioid and clear cells cancers, but also of high-grade serous, which are much more frequent.
Right. Thank you. So 2 last questions. What is your personal opinion on prophylactic protective salpingectomy in non-risk premenopausal and postmenopausal women undergoing abdominal surgery?
I don't think there is a role of prophylactic appendectomy in presence of a normal appendix. I don't think it's a procedure that is performed any longer, at least not in our country. So
Right.
if the woman is asymptomatic and if the appendix is normal, I don't think there is a reason to remove it.
All right. And
also because we don't know. I mean, I don't know if you, Marina, are aware of any data on this, but the appendix might have some immunological function, and we don't know.
So I think it was more of a pronunciation mistake from my part. It was about salpingectomy.
Salpingectomy.
Salpingectomy. That's my French. Sorry.
No. If the woman no longer desires a pregnancy, prophylactic salpingectomy is strongly suggested. But in any abdominal procedure, even non-gynecological procedures. So prophylactic salpingectomy is nowadays strongly suggested, yes. Right.
And finally, what is your opinion about tubal endometriosis for the risk of endometriosis-associated ovarian cancer? Is it a risk factor from Engen?
Sincerely, I don't know. It's not very frequent. I mean, the tubes are frequently involved in adhesions, but finding endometriotic lesions on the tube is not so frequent. So if there are still some doubts regarding peritoneal lesions and deep lesions, probably it's even much more uncertain the effect of endometriosis on the tubes, which is a fairly rare situation.
All right. Thank you. You've got also comments to say, excellent presentation and discussion. Congratulations. Very nice. Thank you. So I will thank you once again, Professor Vercellini, for this excellent presentation. Really, it was a pleasure to moderate this webinar. Thank you to everyone for attending and for your questions. Thank you, EEL, for hosting this webinar. And good night to everyone.
Thanks to you very much. Thanks to EEL and to Professor Oral and to all the people that participated in this webinar.
Yes, thank you, Professor Vercellini, for a brilliant talk, and thank you, Dr. Kvaskoff, for great moderation. And thanks to all participants, and thank you to Dr. Enginoro, who's the person behind EEL webinars and making it possible to meet here today. I'd like to also remind our participants about the upcoming EEL webinar and upcoming EEL events. Our next webinar is on 19 of October in 2021 from Luc Rumbos. He's going to talk about surgery or IVF for endometriosis related infertility. And just a reminder of our EEL Masterclass in Bern, Switzerland is going to take place from 23rd to 25th of September this year. So thank you, everyone, and have a great evening.
Goodbye. Goodbye. Good evening.
Good evening. Bye.